Hello, and welcome to this First Friday Google Hangout on infectious disease outbreaks and our overall preparedness and health security as a nation. Thank you so much for joining us. I'm Susan Dentzer, Senior Policy Advisor to the Robert Wood Johnson Foundation. These First Friday Hangouts are one way that the Foundation seeks to keep people informed about our priorities as a foundation, about the people at the Foundation who are carrying out these priorities, and about the grantees and the other stakeholders who are working with us on this very important work. And today our very timely topic is how well the nation is prepared to handle communicable diseases such as measles and flu, as well as other types of infectious disease outbreaks, and in the context of how well we are prepared overall in terms of our health security as a nation. Our recent experience in dealing and trying to deter Ebola here in the United States, as well as our measles outbreak that we're seeing currently, and the seasonal flu, all underscore for us that these are not theoretical concerns. They're very much in the here and the now. And as you will hear about in a moment, the Robert Wood Johnson Foundation has had a long-standing commitment to these issues in the context of its concerns for public health, and now more so than ever as the Foundation embraces its new focus on building a culture of health in the United States. We have three terrific speakers today to address our topic, so let me introduce them briefly to you now. First, we're delighted to have with us Paul Keener, who's the Director of the Bridging Health and Healthcare Portfolio at the Robert Wood Johnson Foundation, and Paul oversees this area of the Foundation's activities. We're also very happy to have with us Thomas Inglesby, who's Director of the Center for Health Security at the University of Pittsburgh Medical Center. He's also Chair of the Steering Committee behind the National Health Security Preparedness Index, which we'll hear more about in just a few moments. And also we're very happy to have Suzette McKinney, who's Deputy Commissioner of the Bureau of Public Health Preparedness and Emergency Response at the Chicago Department of Public Health. So welcome to all three of you. Paul, we're going to start with you. I'd like you to tell us a bit more about how preparedness in public health connects to the Foundation's focus on the culture of health, and also highlight for us some of the perspectives that were raised in both the Outbreaks report and in the National Health Security Preparedness Index.
Thanks so much, Susan, and good afternoon, everyone, or good morning, depending where you are. I really appreciate the chance to talk with you all this afternoon. And as Susan said, the Robert Wood Johnson Foundation has had a long-standing commitment to public health. We've really been focused on addressing the quality and impact of public health really over the last couple of decades. And as we have embraced this new vision of building a culture of health, so that all in our very diverse society can have long and healthy lives, we see that public health remains a key part of being able to build that culture. And in particular, as we think about today's topic with communicable diseases, we know that the culture of health has to have a strong foundation in the ability to detect and respond to very effectively communicable disease threats in our country and around the world. So if we think about those kinds of threats and the need to prepare for them, to have an adequate system of response, we know that it has to include multiple sectors. It's not simply the healthcare sector or the public health sector, the medical community. We really need to involve policymakers, we need to involve our legal community, businesses, schools, and ultimately, as we're seeing with the measles outbreak right now, it comes down to people in everyday life that really need to have a sense of what is going on in their communities around communicable disease and other public health threats. So I know this firsthand from having served as a county health officer in Illinois and really being involved in a variety of outbreak situations, from small foodborne outbreaks to actually larger foodborne outbreaks that involved exposure of thousands of people in the county I was serving. And then even larger threats like the novel flu virus back in 2009 with H1N1. And again, in all these experiences that I've had, it comes back to the fact that we all are involved. Everyone has to be involved in being prepared for and being able to respond to these threats. And we really have incorporated the understanding that whether we're looking at our country or a community within our country, that we're only as prepared as those that are least prepared among us. And I think that points to the importance of the Outbreaks report that we're going to be discussing today, as well as the National Health Security Preparedness Index. Both of these tools really help keep the issue of public health threats and preparedness and response capacity up in front of all of us and remind us that we really need to be committed to this as we move on building a culture of health. So thank you.
Great. Well, thank you so much, Paul. And now, Tom, we'd like to go to you. You chaired the steering committee that developed this relatively new index. Why have an index like this? What does it tell us? And what does it tell us in particular that relates to what we're seeing now with respect to these communicable disease outbreaks and our overall level of preparedness?
Thanks, Susan. Thanks, Paul, for being here today. This is a great chance to talk about the index. So, why the index? So in the last few years, especially since 2009, H1N1 ended, there have been a lot of questions asked by the policy community, by leadership in the government, both the federal government and the state government. Aren't we prepared yet? Haven't we gotten there yet? Haven't we paid enough for preparedness? How far have we gotten? Questions along those lines, which have been difficult to answer for the preparedness community because people are working on many fronts and there hasn't been a unified way of answering that question. And at the same time, there were many in the preparedness community that were looking for new ways to measure their progress and to benchmark against other states and other cities. And so out of these needs came the idea for an index that would look across the preparedness community and would try to gauge preparedness in its many facets. And CDC got the effort off the ground and gathered up the federal family, gathered up people from Department of Defense and from ASPR and FEMA, and then state health officers, city health officers, the American Public Health Association, the labs, all came together to develop this index over the last few years in an attempt to try and get a sense of where we are, how far we have to travel, what happens if we start defunding preparedness. Can we see the consequences of that if we start to withdraw our support for preparedness programs? So in 2013, the first year of the index was launched, and now we've just had the second year of the index. Back in December it was launched. It is a composite measure of state preparedness across the country. It is 194 measures in 6 different areas of preparedness capacity, and they are pretty straightforward for anyone who works in preparedness. They're health security surveillance, incident and information management, healthcare delivery, countermeasure management, environmental and occupational health, and community planning and engagement. Did I say that one, or did I say countermeasure management? Make sure I got my order right. So it's those 6.
All 6, yeah.
All 6. Those are the categories. We built the index with a couple of core principles in mind, including that it needed to be very transparent. You need to be able to understand it when you see the index, so that people working in the community or working in policy or working in research can get it and can go through it and try and understand where the trends are. We also wanted to make sure it was aligned with the national strategies and with doctrine that we have from our federal government, which it is. And we wanted to make sure that it was no extra burden on states and locals who are already reporting quite a bit to the federal government on their work. So all the data is out there. It just needed to be gathered and organized and put into this framework for us to be able to make an index out of it. And I do want to say just one more thing, that this last year, the index ownership was transferred from the Centers for Disease Control to the Robert Wood Johnson Foundation, and I see that move as a testament to the index's value and to its importance in the community. That Robert Wood Johnson Foundation would bring it on, I think, is really a sign of its value.
And Tom, the index really shows that as a country, perhaps not surprisingly, we really are a patchwork in terms of our level of preparedness. There's variation across the states. There's variation, obviously, within states. And overall, the level of preparedness was rated on the index as 7.4 on a scale of 10. Now, the index didn't call that a C grade, but in most of America's classrooms, that would be a C. What does that tell us?
Well, it tells us that the first thing is that there's been a lot of progress made since preparedness really became a field in earnest in the last 10 years. I think a lot has been done. If you look at the measures themselves and think about where we were 10 years ago, many of these things would not have been possible. But it also shows that there's a substantial amount left to be done, and it shows how important it is to keep going and to sustain what we've already built. I think if you look at the measures and see how time-intensive they are, the capacities that are in the index, you can see that if we withdraw support from them, they go away. It's not something you can build and hope will last forever. These are the kinds of things that require continued investment. And you're right, Susan, there is quite a range of capacity across the country. Many states are very well prepared in one area, but it's more challenging in another. And I think this is the kind of index that we all hope can start conversations and get people talking about how to continue to make progress.
Thanks so much, Tom. Suzette, let's go to you. You're living in this world day to day in the trenches in your role at the Chicago Department of Public Health. What did you take away from both the Outbreaks report and the index that are relevant to the work that you're doing?
Well, thank you, Susan, and good afternoon, everyone. One of the most significant points that stood out to me in the report is the fact that infectious disease threats can arise without notice. And I think just within the last year and a half, we've seen a number of emerging infectious diseases that really stressed our public health and healthcare preparedness systems. Those being MERS, enterovirus D68, Ebola, and now, while it isn't new, we're seeing measles spread rapidly throughout the country. And I think that when these things happen, they have the potential to cause political, economic, educational, and other social disruptions that impact how residents in those affected areas conduct their daily lives. We see hospitals being overrun. Sometimes we hear about fear among the public about where they can go and what they should do. And then governmental leaders are typically put in situations where they have to make critical decisions about whether to close schools or implement other social distancing measures that could limit the spread of disease. But those types of things really impact people's ability to go to work, for example, if they need to stay home with children and just conduct their daily lives. So when you look at the indicators in the report, which we know are designed to provide a snapshot of our strengths and weaknesses across our healthcare and public health systems, what I think we are seeing is that many of those indicators could be met if there were targeted and sustained funding, not only for emergency preparedness and response, but also for core public health services such as communicable disease control, epidemiological capacity, and also vaccine programs for both adults and children. And, I'd love to give you an example. So I guess I would talk about what's going on here with us in Chicago, where I oversee our Public Health Emergency Preparedness Bureau. What we are trying to do is leverage our preparedness funding to try to maintain some of those core capabilities that otherwise might begin to fall by the wayside. We've used preparedness funding to build up our core of epidemiologists. We've partnered with our immunization program to conduct simulations of mass vaccination distribution using seasonal flu vaccine. And in those simulations, we've offered free flu vaccine to the public, but use that as an opportunity to test our procedures for how we would manage medication distribution during a bioterrorism event. We've also required our medical directors, including those that are in our infectious disease programs, to undergo NIMS and incident command training so that they could understand the concepts within those systems and work accordingly when we've had large-scale infectious disease outbreaks to respond to. And what I think is that those types of initiatives have not only helped us build capability, but they've also helped us ensure that when we have an event we're responding to, that we can sustain those efforts even when the event is long-standing. And a perfect example of that is Ebola. While Ebola has receded from the media and the minds of most Americans, it's still a very active response here in Chicago. We have only one of 5 airports in the United States where travelers from West Africa are allowed to enter the country. So for us, that means we have staff stationed at the airport working alongside CDC and Customs and Border Protection. And when we find a traveler that's determined to be at some risk for the disease, we're issuing control movement orders for those persons until they can complete a 21-day monitoring period. In addition to that, we have nurses that are conducting active monitoring to visit and check in with these travelers to ensure or assess whether or not they are beginning to have any Ebola-related symptoms. And then we've established a network of hospitals to take a patient that is believed to be experiencing Ebola symptoms. Not to mention the coordination with several other aspects of the healthcare system, such as EMS and also our county medical examiner. So while all of that is going on, we've also just gotten our first case of measles here. So I think you know, with the National Health Security Preparedness Index as a tool for measurement, we, as Tom mentioned, we began developing this capability more than 10 years ago in response to the 9/11 attacks on the World Trade Center and then the subsequent anthrax attacks in October of that same year. But since that time, we've seen multiple events of national significance related to infectious disease, such as SARS. We saw Hurricane Katrina. We saw the Joplin, Missouri tornado, H1N1, the Fukushima nuclear plant breakdown, Hurricane Sandy, and now Ebola. And I think as a result, our focus has broadened to include not just bioterrorism events, but all types of disasters. I think because every jurisdiction has unique and political characteristics, it's difficult to develop a one-size-fits-all approach to measuring emergency preparedness capability. However, with the development of the National Health Security Preparedness Index, I think we all now have a comprehensive tool that we can use to measure health security. And that's really encouraging to me because I agree with the policymakers and the subject matter experts who did all the work on the index. Preparedness is a dynamic and complex field, and it requires a complex integration of not just systems, but partnerships, resources, and multiple processes to achieve that desired capability. So I think while the tool is standardized, it does allow for each state to conduct a self-assessment that identifies how well they're prepared for these emergency situations and serves as a guide for all of us to continue to strive for higher levels of health security preparedness, which is very exciting.
Well, your comments, Suzette, very much are in sync with those of Tom and Paul on these points that, first of all, preparedness is a multi-sectoral, very broad set of activities, very complex set of activities, to really be ready to address a very complex and different array of threats across the board. So the point that came home in all 3 of your remarks is very much that. Also, as Paul said very clearly, we are only as well prepared as the least level of preparedness and the least of those prepared among us, particularly with respect to infectious disease. And I guess just to come back to you quickly, Suzette, on that point, you mentioned the one measles case you have now. Apparently that was a child who was too young to be vaccinated and was in daycare, underscoring that point that we're only as prepared as the least prepared among us, and the least or the most vulnerable among us can often be the most affected. Is that the way you would see it?
That's absolutely correct. Yes, absolutely. And that's why it's incumbent upon us to continue these efforts, continue the education, and continue working across all sectors to ensure that everyone is aware of what can be done before an outbreak or before an emergency event to help limit the spread and limit the impact when something does happen.
Susan, this is Tom. Can I just add to what Suzette said there?
Please.
I think one of the things that is valuable about the index over time is that people living in any given state can begin to understand by looking at the index how their state is doing compared to other states. So if they're unhappy that they live in a state which has a very low vaccination rate, they can get the data easily on the index and can begin to try and talk about that within their own state and work with their professionals and their community organizations to try and change things as compared to others they may see who are doing things differently.
So to tie back to the current debate we're having on the measles outbreak, for example, as we now know across the nation, there are calls for more mandatory provisions around vaccination, getting rid or at least limiting some of the personal exemption capabilities that some states have put in place for parents to indicate that they have religious or other reasons not to want to have their children vaccinated. How do we approach that, Paul, from your perspective now as a country, as we look to deal with this fact that we have a patchwork of preparedness, we have different laws in different jurisdictions, but the microbes that cause these communicable diseases are not respecters of those differences in laws and jurisdictions, and we really do have a situation of nationwide vulnerability depending on what is the reality in one state or another.
Yes, I think those are such important points, and I think it kind of goes back to this notion of building a culture of health, and one of the key components of that is that we really need to build and maintain and grow our connections with and among each other, because it really kind of goes to the social fabric. It goes to how we are connected and supportive to each other, and that we really do have a shared high value of health. And to me, nothing illustrates that more than measles. Because what we have here is a highly contagious disease, probably among the most contagious viral diseases. We have a very safe, very effective vaccine that has been proven over decades. And we have an understanding that not only is it important for individuals, that are at risk, but we have to understand that it is part of our social responsibility, our shared value system of protecting those, like in Chicago right now, this infant that was too young to get protected by vaccine. That child is protected by all of us having enough immunity across the population to protect her or him. Other people that are living in our communities that have immune disorders, that perhaps are under treatment for cancer, and people that are extremely old. So it really kind of goes to the whole point of a shared value of health and how that gets kind of put into practice. Now, where it does get put into practice is in the policymaking arena. And I think it's so important that we're now having this conversation about what are the limits of just not participating in something that's for the benefit of all of us. How far should we go in allowing personal exemption based on just my own personal beliefs? And we need to have that conversation. We're having that conversation across the country now, and I think that's really a good thing. And ultimately, then it needs to be expressed in our public health laws and regulations that govern such things as school immunization requirements for daycare centers, and so on. So I think it's such a great illustration of what goes to the heart of what we're talking about in emergency preparedness and our entire society. It affects all of us, and we all are in this together.
So we would hope that those of you joining us on this Hangout today, if you have questions, please do send them to us so we can put them to our experts today. Send them to us on Twitter. That's hashtag RWJF, as in Robert Wood Johnson Foundation, 1ST, as in first, Fry, as in Friday. So RWJF, First Fry, for Twitter questions from all of you. So Tom, to come back to this question about variability among the states in terms of level of preparedness, it was interesting. You mentioned those 6 domains that the states were all measured in. It was interesting to see that overall, it looks like the nation is least well prepared in terms of the healthcare delivery system, and best prepared in what is called countermeasure management, and that is to say vaccines, the other kinds of things that we put in place to try to combat various threats. Why is that? Why do we have this gap between our levels of preparedness in across those 2 domains in particular?
Well, I don't think we can say for sure why that is the case. I think that's part of producing the index. Hopefully leads to discussions and conversations around the country and research into that issue. I think we have some intuition. For example, the countermeasure management has many of those issues that are measured in that domain are under the control of one agency or one organization, and have been practiced and funded by various federal grants for many years. So there's been a lot of development of those activities. In the healthcare delivery domains, there are many different players, many different organizations. The system is pretty strapped in many places in the country, and some of the things that relate to taking care of public health or infectious diseases may not be highest on the list in some private healthcare institutions. But you're right, there is quite a range of, from the highest performers to the lowest performers, and in terms of the categories, and that's something we hope that the index will shine a light on and will help generate reflection around the country.
And just, Tom, to stay on you for a moment, what do you think accounts for the fact that even within the same state, you could have an extreme amount of preparation on, say, countermeasures, a relatively weaker to respond healthcare delivery system? Why is it? What's the dynamic, the underlying political dynamic, do you think, or other dynamic in states that leads to this variability just internal to a state?
Well, I mean, one of the things that the index shows is that preparedness is not under the direct control of any particular agency, and not even really under the control of the government in that state or the federal government. There are community-based organizations, there are private healthcare institutions, there are volunteer organizations, and so it's quite possible that within a state, some agencies are very high-performing or have political mandates or have good funding in certain areas, and within that same state, a part of preparedness community is relatively uninvolved or comparatively uninvolved as they might be in another state. But I think each state has its own story to tell, and the index, I think, shows how broad the effort needs to be to prepare for the kinds of things that Suzette outlined earlier: the infectious disease outbreaks, the natural disasters, the industrial accidents, the kinds of things that we all presume we're prepared for.
Paul, to come back to you, we have talked about the measles outbreak a lot. Another clear indication is that we're having a relatively severe flu season as well. This gets a whole lot less attention right now than measles, but we've already had 61 pediatric deaths this year from seasonal flu, according to the Centers for Disease Control and Prevention. What do you think will be the value of the outbreaks report and the index of reminding people that these concerns are constantly with us, where they may recede from the news day in and day out? But what value do you think they'll have in terms of reinforcing our need to keep at this, keep at preparedness on an ongoing basis?
Well, I think particularly in the flu, what it does is point to a set of recommendations that are in the Outbreaks report that really go to the importance of ongoing research and really finding effective vaccines is one of the keys to preparedness and to the kinds of countermeasures that we need to respond to communicable disease threats. We are using really an antiquated set of technologies to develop our seasonal flu vaccines each year. We understand that flu changes, mutates every year. It changes as it kind of moves around the globe. And we have a process for uptaking the vaccine each year. But sometimes that can be a little bit better, and sometimes that can be a little bit worse. And this year we know that the vaccine doesn't give as much protection as it does in some other years. And so we end up having less effective vaccines. So it points to the need for better technology, better research, and really focusing on these threats and not letting our guard down.
And Suzette, to go back to you on that question, what are the messages that you are using to get across to the public the importance of some of these instances of needed preparedness, particularly around flu vaccine?
Sure, absolutely. We are continuing our campaigns to let our residents know where flu vaccine is available. We're working very closely with our healthcare system partners, both in hospitals as well as in private physicians' offices, to ensure that they have vaccine available to provide to their patients. And we are continuously posting information and pushing out information via our various communication channels just to let people know the importance of getting the flu vaccine each year and the level of protection that it provides. But I think one of the things that impacts us in this endeavor is just ensuring that members of the public somehow take heed to that information and those messages that we are providing. And so our goal is to make sure that we are ever present, and as present as much as we can be, pushing those messages out there to really stress the importance of flu vaccine.
So we have a question that's come in from Gene Shan via Twitter. He wants to know what's next for the National Health Security Preparedness Index. And Tom, we know it's going to evolve over time. How will it evolve?
Well, first of all, there's a call for measures on the website right now, which is www.nhsbi.org. So if you are working in the community or have good ideas for measures that exist around the country, we're happy to hear them, and please send them in. But in this year ahead, what we hope for is to identify better ways of measuring social and environmental and economic issues related to resilience and preparedness. That's one big goal.
What would be an example of that? What's a social
an example of more examples of social cohesion in a community. What are we doing for people to support each other within a community? How does poverty or different economic access affect how we're prepared and resilient for preparedness for disasters? And environmentally, what environmental factors predispose to better preparedness or greater hazards in your community? So those are the kinds of, they're partly reflected in the index now, but we think we can do better. We also want to continue to be able to trend the data over time. Right now we only have 2 snapshots. Having a third year would help us identify trends. Are we getting better as a country? Are we getting better state by state? Are we having more difficulty over time? And we also are thinking about how to weight the different measures within the index. Not everything is equally important. They all now currently have the same value, but we know that's not how it should be, and we're thinking about a process of weighting those measures and showing their importance.
Paul, we know that not all the states necessarily were thrilled about where they came out on the index. Who would be? Nobody likes to be measured, and particularly if the measures show that you're not measuring up. What do you think? First of all, why did you get some pushback on it from various states? And what do you think the evolution of the index might do to really help support the ability of states to improve on preparedness?
Well, having worked in the field, I certainly appreciate and understand how difficult it is when a report comes out that points to your state or your community as perhaps having a lower score than neighbors, and getting those tough questions from policymakers about that. I think the importance of these reports, like Outbreaks and like the Preparedness Index, though, is that we do, as public servants, we need to be accountable. We need to be clear and transparent, and we need to be able to have that discussion with policymakers and with citizens about, there are consequences. So, for example, in the Outbreaks report, a state's score in the Outbreaks report may be affected by what policymakers do to lower funding for public health. And so that does create perhaps an uncomfortable dynamic sometimes, but it's something that absolutely needs to happen in terms of those discussions and policy decisions, and we need to be able to engage in that. So I think discussion and transparency is important. The other thing, though, that the index does, and I think Outbreaks report does as well, is point to places that really can illustrate best practices. How are things being done well in a certain community? How can we, in practice in public health or health care, how can we learn from our colleagues that have an example to share that's been lifted up and really highlighted? And I think with the index in particular, as we go forward, one of the things that we want to do is really be able to hold up those examples and really use the whole concept of best practices as a way to improve preparedness for all of us. So that's another way that these kinds of reports can help us.
So we have another question that's come in from Jean Matthews about the ongoing measles outbreak, and asking Paul in particular, but others of you may want to comment as well, how do we reframe the entire discussion now around vaccination in terms of a culture of health, still recognizing individual responsibility for oneself or one's family, but also emphasizing this really is about the culture of health. It's foundational. I think, Paul, was the word that you used earlier. So how do we do that?
Well, I think part of this, and Jean Matthews is someone I know and has a long history of practice in public health, in particular in the law field. And Jean was counsel for CDC for many years, and now he's part of a national network for public health law. The Network for Public Health Law has just released a report this week. They re-released, I guess, a report on state laws and policies related to vaccines and vaccine exemptions across the country. And I think that points to one of the ways that we really engage in building this culture of health is by having these discussions in our communities, in our state houses, in our legislators, about these very important issues of what is the science? What do we know about vaccines? What do we need to have in place in terms of agreements within our society? And then how do we capture those in laws and regulations? So I think that's a big piece of it. But again, I think what we are talking a lot about is the need for public education, public dialogue, and again, realizing that we all have a stake in what we're talking about, whether it's preparedness for natural disaster, or protecting our children or grandchildren when they're in daycare centers and schools.
Susan, this is Suzette. If I can add to that, I would say first and foremost that I wholeheartedly agree with Paul's comments. And I think it's great that we are having this discussion now. But I think what's also important is that these discussions need to continue. And they need to continue not only among our policymakers and for those of us who work in public health and who work in healthcare, but we also need to reach out across other sectors within our communities to encourage them to be having these conversations as well, because this really plays into the issue of community resilience and community recovery. So in addition to those of us who are engaging in these discussions because of our professional backgrounds, we need to be encouraging schools and faith-based organizations and parent groups and other members of the core community to be having these discussions as well. I go back to something that, you know, FEMA has coined, and that is the whole of community approach to solving these problems, because it's great for policymakers to make a decision and develop a new policy, but for these types of issues around vaccination with measles and other sorts of infectious diseases, we need parents and grandparents and other folks within the community to understand their role and their responsibility in helping to implement the policies that we develop.
Well, we've had a wide-ranging discussion about a very important set of issues, and of course we've left a lot undiscussed that the nation continues to face. As we know, President Obama is asking Congress now to increase the budget for research on antibacterial resistance. We know that that's a phenomenon that is growing. We know we have a lot of hospital-acquired infections that we still have to combat. So with all of this on our agenda, as well as dealing with outbreaks and other forms of threats, I'd like to ask each of you for just in closing some brief comments about what you think would be the single most important next step a state could take or a locality could take as it comes to grips with its overall level of preparedness. Paul, let's start with you.
Thank you. I think the most important step at this point is to really affirm that we are all in this together. And I think taking that approach and taking the kind of inclusive approach to real dialogue on multiple levels, as Suzette was saying, really does point to what we need to do at this point. We need to realize that we're all in this together, and we need to keep this top of mind. We can't become complacent, as I think we've been a little bit lulled as some of our vaccination rates and some of the other issues that are highlighted in the Outbreaks report point to.
Tom, your sense about the most important next step?
Well, I think for those leaders in preparedness, those political leaders and those health and emergency management and hospital and healthcare leaders in preparedness, for this community to understand the breadth of preparedness and how we all depend on each other and what it takes, that it's beyond our own institutions, that we need, it's an ongoing process, it's not a specific destination. We're going to be in this for the rest of our lives. Preparedness goes on, just like a fire department is always needed and a hospital is needed, so are the efforts in the preparedness community to take care of its own people. And if we can continue to explain that using things like the Outbreaks report, the index, the organizational examples like Suzette provided today, I think that will make us stronger, and that will help us support all the people who do this work day in, day out.
And Suzette, last word to you, briefly.
Thank you, Susan. Well, as a local, I think for me, one of the most important next steps is to recognize that we all had to start somewhere. And so as a result, we all have varying levels of preparedness. However, we now have tools such as the National Health Security Preparedness Index that we can use to serve as a guideline for us to continue moving forward, to continue pushing the needle. And so I think the obvious next step is to really take that tool to heart utilize it, do an honest self-assessment, and then use it as a guide, again, to continue moving forward and to continue pushing the needle toward where we're all trying to go.
Well, I want to thank all three of you, Paul Keener, Tom Inglesby, and Suzette McKinney, for a terrific discussion. And thanks to all of you for joining us on the Hangout today. We hope you'll come back and join us next month on March 6th for the next First Friday on Health Google Hangout. This one will be devoted to the Foundation's newly announced efforts to commit another $500 million into combating child obesity, in particular by looking at racial disparities among levels of obesity in children and preventing obesity in the nation's youngest children. So please join us for that discussion next month. Thank you for joining us today. Please stay tuned for future First Friday broadcasts. We'll do them once a month for most months over the course of the rest of 2015. Once again, thanks to our panelists today, and thanks to all of you for joining us. Have a great day.